Es un honor para mí presentar al profesor Yvan VANDENPLAS. Su currículum nos tomaría como 15 minutos y como estamos con el tiempo, solamente vamos a decir...
Our short time, I'll just say that he's the chief of the gastroenterology unit in the University of Brussels, Belgium. And the topic he'll be talking to us about is one that in recent years has been widely researched, probiotics. So let's welcome Professor VANDENPLAS.
Hello, good afternoon, everyone. I'm sorry, but despite my many visits to Latin American countries, I still do not speak Spanish. I'll do my best for the future to learn it, but so you will have to do with an English presentation. As it was said in the introduction, my topic will be about probiotics. Are they all created equal? Are they diverse? Well, I can be very short, in fact, because if you listen very carefully to the two previous speakers, it's obviously that they cannot be the same and that they are not created equal. But I'll try to further elaborate on that and convince you. So I'll talk to you about introduction, then the different strains, come to products and conclusions. We all like to start with a short history or story, and if you talk about probiotics, although it's now a very hot topic and discussed very heavily in literature, it's in fact not new at all, because Plinius the Old, in 76 years before Jesus Christ, already recommended fermented food in the treatment of acute gastroenteritis. So the idea to use microbes and that they could be also healthy and not only harmful for the human is certainly not new, as it exists for already much more than 2,000 years. We also heard already this morning that the idea of using microbes in the treatment of diseases or using microbes to improve human health is a very natural idea, because mother's milk, breast milk, which is the best way how to feed all infants, does not only contain very large amount of prebiotic oligosaccharides, it also contains very small amounts of living microorganisms. It's true that the amounts of bacteria present in mother's milk is relatively low, but they are there, they have been cultured, they have been identified. So mother's milk is not sterile, it contains living microorganisms, it contains probiotics. So it's certainly also a very natural idea. And this slide just gives you an idea about the probiotics, bacteria, and yeast, which are used more commonly in healthcare. And what I would like to do is to show you how they differ from each other, and certainly how yeast probiotics are different from bacterial probiotics. This is illustrated in this slide, where here's the pointer, which shows you that the yeast Saccharomyces is much larger than the bacteria here, which is Salmonella, or here Salmonella, and here the yeast. So there is a huge difference in volume. Also, there is, for the guidelines of probiotics, what we need to develop is a safety assessment, which needs to be done in vitro or in animal, and phase 1 human trials. And you need also clinical efficacy, which is shown. So you do not only need fundamental research on the microorganism itself, you also need clinical studies with, I would say, not the strain, but with the product that you want to evaluate, because the way how a product is commercialized and produced certainly also has influence on the viability of the strains present. So clinical trials should be performed by preference in double-blind trials, prospective, randomized, and with the product. And it's clear if you look around you that definitely not all probiotics are the same, because there are the natural occurring probiotics, as in fermented foods, yogurts. They have been commercialized. Some strains have been isolated and improved. And then you have food supplements, and then you have also probiotics, which are commercialized as medications, as drugs. And so it's clear that when we use the word probiotic, we might be speaking about food, healthy food, or we might be speaking about medication. And of course, what you expect from that is totally different. You do not expect from a healthy food that it will treat diseases. So that's why there is so confusion about when the word probiotic is used. This is just some slides to show you that yogurt, despite the fact that it is absolutely sure that it's a very healthy eating habit, that it has failed to demonstrate therapeutic efficacy here in the prevention of antibiotic-associated diarrhea, and here the same for kefir, which has been shown to be not effective. On the other side, a study where attention was focused on side effects. It's obviously that by eating yogurt, here eating kefir, the number of side effects of your treatment was decreased, which confirms that these kind of probiotics may have an effect in healthy eating habits. And then there is, of course, the probiotics which are commercialized as medication, and today is a day which is organized by Biocodex, the producer of Saccharomyces boulardii, and Nicolas Coudurier in the introduction told you about the history about this product, and so I will not come back to that, but it's clear that it has been commercialized now for more than 50 years as a medication. In fact, it's the first probiotic medication which was ever commercialized. There is the problem of strains and specificity of the strains, but there is certainly also strains which might be depending on the indication if they are effective or not. What you see here is the effect of Bifidobacterium lactis on the growth of children, where you see, in fact, that if you evaluate it in HIV-negative children, it's not effective. And if you evaluate it in HIV-positive children, it is improving the growth, which shows you at the same time the efficacy on reduction of infections, of course, and the safety profile, because HIV children are immunocompromised. And then you have this study, also the same strain, which is not effective in rotavirus gastroenteritis, but which is effective in non-rotavirus gastroenteritis. So it's not only strain specificity, you have also to consider indications whenever you talk about strain specificity, because a strain might be effective in one situation and it might not be effective in another situation. So let's talk a little bit about strains, and the first presentation you heard a lot about that, but I thought I will try to simply try to explain to you what the difference between genus and species and strain is. So the probiotic candidate must be a taxonomically defined microbe a combination of microbes. And for bacteria, the best known examples are lactic acid bacteria with the genera Lactobacillus and Bifidobacterium. And you see from the genus Lactobacillus, up to 116 different genus have been described and have been identified. And I just listed some of them which we know, which we use as probiotic, but you certainly have also lactobacillus strains which are not used as probiotic. And this is the way how they are classically presented with the interrelation between the different strains, but rather difficult to understand if you are a pure clinician like me. Then this slide summarizes you the microorganisms which are considered as probiotics. And again, it also shows you that you should always be very critical looking at this kind of tables, because this comes from an official paper. But you see that Saccharomyces is here classified as non-lactic acid bacteria, while it's absolutely yeast and not bacteria. But this slide summarizes for the rest the probiotic strains which are most frequently used. Now, what's the difference between strain and species and subspecies? I tried to just illustrate it with classifying myself as being a human, and so that's the domain of bacteria and the lineage of Phyllium. So I'm a male, and then you see how it goes down, and then you go to the species, which is my family name, but that doesn't still not say anything, because there are many VANDENPLAS on the world, but there is probably only one like me, although even then you have to be very critical, because if you do Google images and you put in my name, you get a lot of nice pictures, but they have nothing to do with me. So be always very critical about strain specificity. Look to the details, because it's not always as simple as you think. So the taxonomy for Saccharomyces boulardii, it belongs to the fungi, and you see phylum and class and order and family and genus Saccharomyces, species Saccharomyces boulardii, but not all Saccharomyces boulardii are the same. So it's important to focus also on the strain, and the strain from Biocodex is a Saccharomyces boulardii CMI I745, which is the strain of the Saccharomyces strain from Biocodex. So again, genus, species, strain, and Saccharomyces boulardii does in fact not tell you very much, because there are very many different Saccharomyces boulardii out there, and if you use it in clinical situations in the treatment, as we said, you need to use these strains for which there are clinical trials that showed efficacy and safety. And the clinical trials we are always talking about is with this specific strain from Biocodex. And so Saccharomyces cerevisiae, which is sometimes said in literature to be the same as Saccharomyces boulardii, is certainly not the same. It's totally different. It's different species, I would say. So specificity of strains, yes, beyond doubt, and depends, of course, on how specific the property is you're interested in. If it's a very general effect, or if it's a very specific effect. It also will depend clinically on the dosage you are using of that specific strain, so not only the specific species, subspecies, but also the indication, as we already said, but also the dosages, because this shows you that depending on the dosage that you're giving, you see an efficacy or you do not see an efficacy. And this is an example of studies with Saccharomyces boulardii, where you have in antibiotic-associated diarrhea, where you have one study which is not effective, and that's probably because the dosage in that study was much lower than in the other studies. So yeast versus bacteria, they are definitely not the same. If you look, the presence of in human flora is much more for bacteria, of course, than for yeast. The type of microorganism is totally different. As I already said, the cell size is totally different. The cell wall is different. The growing conditions are different, and the yeast is much more resistant to gastric acid than most of the probiotic bacteria. So gastric acid will kill a lot of probiotic bacteria. Transmission of genetic material is possible for bacteria, is not possible for the yeast. Resistance to antibiotics for some bacterial probiotic strains, there is resistance, but for a majority of the natural occurring probiotic strains, there is no resistance to antibiotics, while the yeast is resistant. And of course, the effect on the immune system for Saccharomyces boulardii has very clearly been studied. Toxic receptor site inactivation, trophic effect on the mucosa, shown for the yeast, not shown for the bacteria, which is one of the major mode of actions of the yeast. Inhibition of inflammatory response, clearly shown for the yeast, shown for some bacterial probiotics, but not for all. Production of short-chain fatty acids, the same, and naturalization of endotoxins, the same. So this shows you, this slide summarizes you major differences between bacterial probiotics and yeast probiotics, showing you that they are indeed not the same. And this slide summarizes the modes of actions which have been very well studied for Saccharomyces boulardii, with an intraluminal action, an antitoxinic effect, antimicrobial activity, modulation of the intestinal microbiota, metabolic activity, a trophic action on the mucosa of the intestinal tract, which is only occurring with the yeast probiotic, and mucosal action, anti-inflammatory effect. Then you have, of course, we talked about bacterial probiotics. You have also bacterial spores, which are commercialized. Now, these spores, it's not known if they are resistant to acid or not. And in order to become living bacteria, these spores need to be reactivated to cells and then to reproduce themselves, to multiply themselves. If that is happening or not is in fact not really known, and it seems a very complicated process to have this kind of efficacy. Products itself, I mentioned it in my introduction, that it's not only species, strain, but on the product level that you have to be very careful. We in Belgium have a lot of copy products of the original Saccharomyces boulardii products. They have not all been identified to the subspecies, but it shows you that if you prescribe Saccharomyces boulardii, the pharmacist could give any of those 15 products. This is the original one from Biocodex. And what this slide shows you is the survival of the yeast after being 2 hours in gastric acid. And then you see that at the moment you start initially, the amount of living yeast is more or less the same in all these products, but that after 2 hours in gastric acid, except for the original one, they all have decreased by about 50%. So in fact, you give only half of the dosage which you're giving. So this illustrates why I was saying that clinical studies, you should not refer to clinical studies with the species itself, but with the product itself, because the quality of the product may be very different on the way, from the way it is produced. This slide comes back to the difference between bacteria and yeast. It's the recommendation from Yvan that was published last year to use probiotics in the treatment of acute gastroenteritis, where we said that for Saccharomyces boulardii and Lactobacillus rhamnosus GG, there was the best evidence to be recommended, but also we recommended to not use one probiotic strain because the Enterobacter faecium could transfer its genetic resistance to pathogens to the commensal flora, and therefore that's certainly something that you would not like to happen. And that's mainly the major risk that you take if you prescribe products for which there are no data at all, for which have not been tested for their efficacy, but neither for their safety. Because who knows? Maybe they could also transfer some genetic resistance. So if you use it in medication, be very careful. Use only these strains and products for which there is efficacy for which efficacy has been shown. So this brings me to my conclusion of my presentation. I hope I showed you that although at the first look, the two figures look exactly the same, they definitely are not. There are differences. So each probiotic strain, subspecies is different from another. Use that one as medication for which there is evidence in literature about efficacy and safety. And just as human beings, also the probiotic bacteria and yeast that we use, they are all created different. Thank you for your attention.
Thank you. Thank you, Yvan. Preguntas del público.
Thank you. Are there any questions from the audience? Dr. Warner,
Los micros, por favor.
please pass a microphone to the doctor.
Well, it was very interesting, the data you showed on the resistance of the different products in the pharmacy on acid.
Yeah.
And you mentioned that it's only half, but if this is logarithmic count,
Yeah.
means that you have only 1 in 100,000. So
Absolutely.
5 logs reduction. So it's not half, it's really...
Yeah, I fully agree, and sorry for my mistake of being too positive about the other products.
Preguntas. ¿El público usan probióticos?
Any question? Are you using probiotics?
Sí, ¿los usan bien o no?
Do you use them well?
Aquí hay una pregunta. Por favor.
Here we have a question.
Adelante, aquí el micro. ¿No? No era pregunta, sino que se utilizaba.
Oh, that's not a question. You were saying that you do use them. Okay, thank you very much. So what situations do you use probiotics in?
¿De dónde viene?
And doctor, where are you from, please?
Mi nombre es William Cabra, vengo de Bogotá.
My name is William Cabra. I'm from Bogota, Colombia.
Y pienso que
And I think that after God, the only thing keeping us alive is our immune system. And our immune system is, of course, in the digestive tract in a ratio of 60 to 70%. So we are what we eat. Personally, in my experience, I have used them in order to prevent diseases of any kind, allergies, infectious diseases. And today I learned from my Panama colleague that even dysautonomy has something to do with this. Pregnant women, well, that's whom I start using multi-species strains with. I am thinking, I project this to the newborn when there is gastrointestinal motility disorders such as reflux, allergies of the skin, respiratory, digestive kinds. In other words, in order to avoid allergies. And after 25 years of practice, I find that I have a lot of healthy children in my practice. Some of them actually are playing sports, representing our country even. That's why we today are going to beat Argentina, by the way.
If I may make one comment, I think there is a huge difference, as you were alluding to, in using probiotics as in healthy food. And I think what we are missing there is that now that we know that there are probiotic strains in mother's milk, why not put these strains into infant formula, for instance? Because now we put foreign strains into that. And what we want to mimic is the effect of mother's milk with second choice infant feeding. But that's totally different of using probiotics as a therapy in disease. So I think you have one interesting field is prevention and general health development and immune system development in infants. And that's, for us pediatricians, a very extraordinary, interesting field. But the other side is acute diarrhea or whatever other therapeutic indication where you probably need a different immune response than for your development of your healthy immune system when the child is born. So that's two different, totally different areas of application of these microorganisms.
Una pregunta de...
We have a question. My name is Fernando Burgos from Argentina, Austral University. First of all, we are in fact going to beat you 2-1. Higuaín and Messi are going to score. And if Messi has a good, stable microbiota, of course. In fact, I think he's dieting for his game. Now, my question. One of the main problems we face in pediatrics and the use of probiotics is the immunodepressed patient. I have found patients with Crohn's disease, chronic diseases, with Crohn's disease. There are very few alternatives. What is your experience? What works? Tell us in the literature what kind of probiotics I could use for immunodepressed patient, transplant patient, acute diarrhea patient, or Crohn's disease?
Yeah, I think it's a very challenging question to which I will not give you an answer. Why? Well, because if you read the leaflets of all the probiotics, they will all tell you not indicated in immune-compromised patients. And that's because we are very afraid of using living microorganisms in immunocompromised patients. However, and I voluntarily did show you that slide on which probiotics in infant formula in HIV children resulted in a better growth. There are studies with Saccharomyces boulardii in HIV patients showing reduced incidence and severity of diarrhea, and all these studies show safety, do not show adverse effect. Yet everyone opens his umbrella and says, we don't want that our product is used in immunocompromised patients. And with Yvan, 1 year ago, we said we would do a clinical trial in exactly immunocompromised children, and we did not find a company who was ready to go for that because everyone is afraid. Another example is the preterm, which is certainly also immunocompromised, and all the data show a decreased or same risk of necrotizing enterocolitis, a decreased risk of septicemia, a decreased risk of mortality, or the same, never an increased risk. So also from there, and it's now recommended, opinions for probiotics in preterms differ quite a lot, but there are a lot of people who absolutely recommend it and will say when neonatologists are going to change their mind and start to give probiotics to every preterm because of the maybe efficacy and safety data that have been shown. Yet, we cannot recommend to give one specific strain into these immunocompromised patients because the studies that have been performed are with different protocols, with different strains, and so there is no active recommended attitude today in this kind of patients.
Otra pregunta del
Doctor.
Otra pregunta, sí.
Francisco Cabrera. de
Doctor, my name is Francisco Cabrera from Mexico.
Doctor Iván, ¿durante cuánto tiempo
Doctor,
hay que administrar estos probióticos?
How long should we administer these probiotics, for instance, in acute diarrhea
En un paciente alérgico.
or in a patient with allergies?
¿Cuánto tiempo
And
dura
how
su efecto?
long are
¿Cuánto tiempo es
their
el que protege?
effects, their protection effects mostly?
Yeah, well, the duration of treatment depends on the indication. If it's for acute gastroenteritis, it's 5 days, 7 days treatment, depending on the protocols that have been used. But if you want to use it for the prevention of allergy or other preventive effects, you have to use it for months, like the probiotics which are in infant formula. They exist now from starter formula, second stage, third stage. So infants get it from birth up to the age of 2-3 years all the time. Whether it's necessary or not, that's a different question. But so I think since we are all the time in our environment in contact with microbes, to add some extra microbes in food is no problem for the duration of doing it. Again, if you use it in treatment, it's different. However, there are situations like the HIV patients where they are taking the medication, the probiotic, for a very long time. Also in inflammatory bowel disease, it's for months. I mean, most studies in Crohn's disease are negative. Do not say they are all negative, but patients have been taking it for months without adverse effects. So duration of treatment depends on indication. And the second question was?
La segunda pregunta, doctor, era ¿cuánto tiempo era el efecto?
The second question is how long do effects
How
last?
long does the effect persist? Well, what has been shown now is that whenever you administer a probiotic as treatment, it disappears from the gastrointestinal tract after 2 weeks. So, and there is only one study in acute gastroenteritis where the children were treated for 1 week and they were followed for 2 months. A study from Pakistan, and it showed that even after 2 months, there was still a reduction by 50% of new episodes of acute gastroenteritis. So that may suggest that the probiotic disappears from the gastrointestinal tract, but that the immune modulatory effect may persist for longer. And a couple of weeks, couple of months, unfortunately, the study I'm referring to was an open study, and there are no double-blind, placebo-controlled studies that have been performed up to date to confirm that. Whether there is an effect, prolonged effect, if you give infant formula with probiotics as the first contact ever that the gastrointestinal tract and the immune cells have with probiotic strain, whether that is an effect that may persist for long or not, no one knows because it has not been studied.
¿Alguna pregunta más? No veo, pero
Any other question?
la última.
Last question.
¿Va a ser el score del partido? O...
Are you going to talk about the
¿Aló?
score?
Ah, doctora de Chile.
Doctor,
Mi nombre es Andrea Urrutia de
my
Chile.
name is Andrea
Somos
Urrutia
poquitos,
from
así que
Chile.
voy
We
a
are very
aprovechar la
few, so
oportunidad
I'm going to take this
para hablar un
opportunity
poco.
to
La verdad
ask
que
my
no se peleen
question.
mucho si
Don't
gana
fight too
Colombia o
much
Argentina,
if
porque la verdad
whether
que el campeón
Colombia
de
or
Latinoamérica
Argentina
va a
wins
ser
or not.
Chile.
It's going to be Chile anyway, so
Así que para que todos estén tranquilos.
so you can be calm
Doctor,
about that.
mi pregunta va
Doctor,
orientada
my
más-
question.
Belgium will become world champion.
Bueno, eso puede ser, pero falta.
Maybe, but that's still in the future.
Doctor, yo quería ir un poco más a lo que
Doctor,
usted hablaba
I
de
wanted
la
to talk a little
importancia
bit
de las
about
cepas.
the importance of
No sé lo que
strains.
ocurre en los países,
I don't know how it
especialmente en
is
Europa,
in
pero
European
la primera cepa
countries,
que llegó a
but the
Chile
first strain
efectivamente, el
we
original, que es el
found in Chile
Biocodex.
was the
Pero hoy
Biocodex
en día
original one.
existen,
Nowadays,
varias
however,
copias.
there are several
Tenemos
copies.
muchas copias
We
en
have
Chile de
many copies in
Saccharomyces
Chile of S. boulardii,
y la industria,
and the
los laboratorios no
industry
especifican
labs
esa cepa.
don't
Yo no
specify
sé
the
qué
strain.
ocurre en el resto de los países.
So I don't know how it is in
Y
other countries.
los médicos en general
Doctors
están
in
poco
general are not well
respecto a eso.
informed
Y
about
se
this,
indica de
and
forma
we
más o menos
use
pareja,
it
o sea,
more or less
indiscriminada,
uniformly,
una
that
u
is
otra cepa. No sé qué
indiscriminately regarding strains. I don't know what your opinion is about this.
Yes, well, that's why I showed that slide of the different products in Belgium, and that's why I also emphasized on the importance of the subspecies name, that Saccharomyces boulardii itself is not enough, but you need to have the same strain as the one from Biocodex, because that's the one with which the clinical studies have been performed. And you cannot extrapolate from these findings to other products, because they may have different quality and they may have different subspecies in it. So whenever you prescribe probiotics as a medication, you should just have exactly the same control of quality and evidence as for every other medication that you prescribe. And it may be so that for antihypertensive drugs, if you copy exactly the same molecule, that the difference is not that important between a copy product and the original, or for a PPI, a proton pump inhibitor. But it's obviously what literature learns us is that when you talk about living strains, as in probiotics, that it's not just copy-paste, because you can copy, but the paste most of the time goes wrong, and it's not exactly the same product, so you cannot extrapolate.
Okay, I know we're limited on time, but I still want to ask a question, Doctor. This question is about recommendations for the use of probiotics by Yvan. They give us a strong recommendation, level of evidence low. That seems a contradictive. Could you clarify this?
Well, that's because the recommendation is strong, but if you look at the quality of the studies, then all these studies contain some methodological weaknesses according to the new grade systems to evaluate these studies. So it tells you these are randomized controlled trials. They are not bad, but they are not of the highest scientific level that you could want to have. On the other side, if you take the evidence that there is, we feel that you can make a strong recommendation, despite the fact that the scientific quality of the evidence is not of the highest level.
Thank you, Dr. VANDENPLAS. I now invite our next speaker to the stage.